Audio Jungle.
How can MDH better serve as a health strategist partner for policymakers in diverse communities? And how do we help particularly agency staff acknowledge how values and assumptions guide collection and use of data, and how we can help staff better identify and engage stakeholders in development of all of our data work? We'll also be contracting with a vendor to evaluate how we could best organize our data and use advanced analytics to put the data back in the hands of communities and policymakers like those of you in this room. What we would expect to see if this were enacted is that across geographic, racial, ethnic, and cultural communities, Minnesotans would finally be able to access data to understand the underlying causes of health disparities and begin to craft policy solutions to eliminate those disparities. Community-informed data is going to be a powerful resource for policymakers' decision-making on a range of issues that affect Minnesotans' health. And just as a couple of examples where we know that this could make a difference, we would highlight transit corridor development, labor practices by major employers, things like paid leave, and then of course criminal justice policies and the ramifications for those as well. So I covered a lot. I can't actually stay for the rest of the program, but I do want to open it up to questions and just give a couple of minutes for discussion or questions about my work or the agency's work or the governor's budget. Don't ask me if the president's executive order is legal, because even though I am a lawyer, I'm not that kind of lawyer. And I'll probably just defer to the attorney general, who might have said it was unconstitutional today. Yes, ma'am.
Can you explain a little bit where the disparities exist?
Sure. The disparities really exist, both in race and in geography. We know that communities of color in Minnesota are experiencing some of the worst health disparities. We don't actually know that much about immigrant communities specifically. Again, kind of going back to this data proposal, almost none of the data drills down to the level where we could even be able to speak specifically to an immigrant community versus just the racial group that they're included in. But I will add, and this is important to work at the Capitol as well, if you look at a health disparity based on a zip code, and you can pick a zip code, and generally that there's a higher prevalence of an immigrant community in that zip code. A lot of times that zip code and the disparities that they're experiencing, the disparities and health outcomes will be just as bad in a rural zip code. So there really is a statewide problem here, and not all zip codes are equal, and so it's actually causing people to die sooner. Tony Aiton out of California Endowment has done a lot of research, and he's talked to folks here. Some of you may have been at those presentations. You can literally look at a map of Highway 94 and you live 10 years longer if you're at a different exit. In some cases it's 20 years longer. So that's kind of how we see it and how we're trying to get at it with some of these proposals. Yeah.
What is
and say who you're with, or if you're with an organization.
I'm Carrie Vogelsang. I'm an independent consultant. What has been the challenge up to this point in actually drilling down to that level of data, since the report was 3 years ago? And I think it's a challenge that other agencies have. And so is it the systems aren't allowing you to get into that point, or what is the money gonna, is there proactive, knowledge at this point what the barriers are, and that, this can be, I don't know, as productive as possible, not just saying, admiring more of the problem from a data standpoint.
Yeah. Yeah, I would say it's all the above. The way we're funded, we're 52% federal as an agency. So we don't actually get a lot of state money. A lot of our money is federal. And the things that we're funded to do are broad sort of preventive health practice services and programs. And a lot of times the funders don't necessarily include elements for health equity. So I'll give you a great example. We got federal funding to prevent the spread of Ebola. Well, that money went to epidemiologists and testing and lab services. But the thing that was the most effective way to prevent Ebola in Minnesota was working with the Liberian community and explaining to them what's happening there, what's happening in their home country, why we don't want them to necessarily go to visit their relatives who are sick, and really working in an equity way, in a collaborative way with the Liberian community to prevent Ebola from coming back to Minnesota. So there hasn't been an understanding in recent years that sometimes the equity solution is a more effective solution. I think Fortuna's tried to make that case, when she's talking about funding for Isuroon, that the equity and understanding is just as important as funding the prenatal care. But a lot of what gets funded is services, and not always the data. So we're excited to have a piece of the governor's budget that really gets to data, that really gets to equity. Yeah.
My name is Joe Fair, and I'm from People's Center. Has MDH looked at ways to create programming across sectors? Because it seems like everything is happening in silos, and when we talk about the social determinants of health, it always seems like there's one or two things lacking from getting people to have like an equal or reaching optimum health.
Yeah, absolutely. Yes, I mean, the answer is yes. And again, it's sort of back to the funding answer of, can you get the dollars to be flexible enough? I'll give the SHIP program as an example, that the statewide health improvement program is broadly available to community health boards. So those are really county run. And, they have to use it for certain chronic disease prevention, for things like obesity or tobacco prevention, but they're given flexibility to really engage with community leadership teams, to really talk about what are the needs of that community that are going to influence these chronic disease or these types of illnesses and disparities in their own community. One of the new requirements of that contract is to have an equity component to the work at every community health board level. So, I mean, that's that's one way you can adapt some of the current funding, but you're right. I mean, it is a largely, overwhelmingly sort of us trying to take siloed money and make it more flexible for grantees, for local government, for partners. Question in the back.
Hi, yeah, my name is Tracy Armstrong, and I work at the Friends Social Service. The woman that spoke before you did a really nice job of explaining how trust is such an important factor in building the relationships. And so as you're talking about going out and doing the home visits, I'm wondering, do you utilize community health workers, or will you emphasize using culturally appropriate clinicians in some way or fashion?
Yeah, that's a great question. I don't know if everybody could hear. It was the question whether home visits would be community health worker or clinicians, and how do we get that to be culturally appropriate. There is, so with home visiting, there are evidence-based models that have a higher return on investment. Not every county, not every community health board uses an evidence-based model, so there is some flexibility in terms of how you want to approach it. And in the American Indian community, there has been actually an entire evidence-based practice that is culturally based called Family Home Spirit. That was very expensive to develop, and actually took a couple of years to get into practice, and is now working really well. And it would be great to see that in other communities as well. I think a lot of that is going to be driven at the local level, because we really are the funder of the family home visiting. It is delivered at the local level, and it can be either county or nonprofit delivered. Typically, it is done through a nurse practitioner, not a community health worker. Any other questions? Well, thank you again for having me. Thank you for the work that you guys are doing and being partners with us on this. And again, hope to see all of you at the Capitol talking about these issues.